Welcome back. This is Morning Express. You're watching, and of course, this is time to take a look at your health. Wednesday is a day when we focus on your health, and today the biggest issue that we've prioritized is vaccination, and we shall be dealing with vaccination in terms of COVID-19. But even as that continues, there's one that is going under the currents, and that is the vaccination against malaria, a disease that has ravaged the continent of Africa and beyond for years and years, and those that suffer the brunt of this disease are children. So this is it's very important to focus on the vaccination that is ongoing right now in the very early stages and figure out what the future holds as far as ridding ourselves of malaria. Now, joining me on Zoom is Dr. Masika, Dr. Moses Masika, who is a virologist. He's here, a regular here on the show. But here with me in studio is Professor Bernard Ogutu, who's a Chief Research Officer at the Kenya Medical Research Institute, that is popularly known as, or rather abbreviated as, KEMRI. Thank you so much, gentlemen, for joining us here on Morning Express. Now, to kick this off, I'd like to get an overview of the situation regarding malaria in Kenya and in the continent. I'll start with you, Professor Ogutu.
Thank you very much, and it's my pleasure to be with you in studio just to shed light on this. In the last decade, we have seen a decline in the endemicity or the prevalence of the disease across Africa. And this has increased quite a bit, and we have seen that over the last 10 years, especially the first 5 years between 2010 and 2015. We show quite a bit of a rapid decline. And from 2015, there has been much more of a plateauing, but we still see quite a bit of impact, and this can be attributed to some of the interventions that were put in place, changing the treatment to the combination therapy, the wide use of bed nets, and also several initiatives that have been put across, and lots of investment put into the control of malaria across the region. In Kenya, even recently, as per the interim data that we have from the indicator survey that was done last year, we are seeing quite a marked reduction in the prevalence of the disease in the country. And we were worried that COVID impact was possibly going to wipe out that gain, but I think this has been promising, and we have seen quite a reduction in the national prevalence, dropping by a factor by possibly 3%.
And you've talked about combination therapy. Perhaps someone's watching at home and they're wondering what on earth that is. Could you please explain to our viewers what combination therapy is?
When we talk about combination therapy, which has now been used for almost two decades in the treatment of malaria, is where we don't use a single drug, but we use two drugs that are combined and together, so that we can attack the malaria parasite on two fronts at two different levels of the parasite life cycle, its own genetic makeup. And I think that's why we see, and that can help us delay the emergence of resistance that has been a big problem before.
And we'll get into resistance and drug resistance when it comes to malaria later on. I'll also like to dig deeper into the development of immunity far from vaccines. But Dr. Masika is with us, joining us via Zoom. I'd like you to get your opinion on the development of a vaccine. To quote Winnie Byanyima, who's the head of USAID, she has said that it is curious that when it came to COVID-19, we had very quick response when it came to developing, a vaccine. But when it came to HIV and AIDS, it has taken years and years and years, no vaccine yet. It points to, according to her, it points to a lack of goodwill. And we're looking at malaria. We are not even, in a very comprehensive stage when it comes to vaccinating our population. So what say you about that? And perhaps what do you foresee in the near future as far as malaria vaccination is concerned?
Thanks, Trix. And I'm glad that Professor Bernard is in studio to comment on malaria, because it's really the authority on this. My view is that comparing these different bug or diseases, malaria, HIV, and COVID, and the speed with which vaccines have been developed is not really fully, you cannot really compare them for many reasons, because in as much as they are all disease-causing bugs. They are very different characteristics. For example, we know HIV, the challenges that come with developing vaccines. I think there has been substantial goodwill on the front of funding HIV vaccines, although not as much as COVID, but the attempts or the platforms that have actually worked for COVID, many of them have been attempted also for HIV, and the approaches will continue to change.
Right.
For malaria, I think, yes, we've not had as big an investment traditionally in vaccines, but in the last 10 years or so, we've seen a reinvigoration of the process. And a few years ago, remember, we had a vaccine that was actually licensed and was tried at least in 3 countries in Africa. And although the vaccine only worked in about 40%, to about 40%, it was still a significant achievement. Thinking about that at the time, malaria was causing about 500,000 deaths. So if you can reduce that by 40%, then it is a good thing. We are seeing a promising vaccine now that was tested in Burkina Faso in a phase 2 trial that is going above 75% in terms of efficacy. And I'm hoping that as we start phase 3 trials, the funding will be available to make sure this is completed as soon as possible. But yes, indeed, we've seen unprecedented collaboration, unprecedented goodwill for the development of COVID-19 vaccines, and that has helped in speeding up the process. And we can hopefully transfer some of this goodwill to the other vaccines as well. Because COVID-19 has shown us what is possible when we pool our resources and our purpose.
Yeah, and when it comes to development of vaccines and prioritization, would you say perhaps the economic standing of the regions that are affected by a disease actually plays a role in the development of those vaccines, or perhaps the interest of big pharma in investing in that particular vaccine?
Yes, I mean, the return on investment has always been a key concern on medicines and vaccines. And this is because most of the innovation in this field has been driven by private interests.
Yeah.
The countries that are often suffering from malaria are not those that typically spend a lot of money on vaccines and even medications. And so for that reason, it has been left to international technical organizations like WHO to push for this kind of investments. And if you compare with other diseases that in places where people are willing to pay any amount for the new drugs developed, investors look at that as a good return on investment, because the cost that goes into developing, say, doing a clinical trial is upwards of $40 million. So you have to be sure that money will come back, otherwise your investors and your shareholders will have problems with you. And so for us to be able to deal with some of these issues that are occurring in places where the return on investment is not clear, we have to use a different approach of funding, either from governments or from other, should I say, philanthropists who can fund these kind of things. And we've seen quite a number emerge.
Yeah.
What's changed actually with COVID-19 is that the problem was so serious that the funding was not left to private companies. I'm sure you remember governments booking in excess of 1 billion doses of the vaccine in advance, and this money went into the development. And that removed the challenge of investors having to fund the development process, which can be quite slow because you have to convince people to raise money to fund a process they're not sure what the return will be.
Okay. Now we'll get Professor Gutu's take on that, the development and prioritization, and perhaps the ability of governments to actually invest, given that some of the countries that are affected by malaria largely in developing countries or still dealing with many other problems and perhaps cannot afford to have the economic clout to have their own development of vaccines. But let's take a look at this story that surrounds malaria elimination. Kenya is aiming to end malaria by 2030 as it faces financial challenges in implementing its malaria strategic plan from 2018 to 2023. Early this year, President Uhuru Kenyatta launched the End Malaria Council, which is supposed to mobilize local resources in implementation of malaria strategy. Even with this, Kenya still has a long way when it comes to ending the disease. Our health and science reporter Beldine Waliaula gives us a glimpse of the malaria situation in the country.
An estimated 3.5 million malaria cases reported each year, Kenya still has unfinished business when it comes to eliminating malaria. Of more concern is the 10,700 deaths attributed to malaria each year, mostly among young children. Kenya has set its sights on ending malaria by 2030. But first, it has to reduce the malaria incidences in the country by 75% by the year 2023. The epidemiology of malaria in Kenya is influenced by altitude, rainfall patterns, and temperature. 4 malaria epidemiological zones are found in Kenya. Low-risk malaria areas cover the central highlands of Kenya, including Nairobi, and endemic areas, which include Lake Victoria region. Even though the journey looks long, Kenya has witnessed a significant decrease in the prevalence of malaria from 8% in 2015 to 5.6% in 2020. This is according to Kenya Malaria Indicator Survey done last year. In the Lake region, which bears the highest burden, the disease prevalence reduced from 27% to 19%, which can be attributed to an increased use of mosquito bed nets by communities.
Our plan, as per our primary health care guidelines, is not to wait for the disease to occur, but to effectively prevent it from occurring in the first place.
Malaria hospitalization in the country has also reduced from 113 per 1,000 of the population to 86 per 1,000 in the population. Helping in the fight against malaria is the RTS malaria vaccine. At least 190,000 children in 8 counties have received their first dose of the malaria vaccine. The jab, which was launched in Kenya in September 2019, reduces a child's chance of contracting malaria by about 40%. The jab is being administered in a 4-year piloting scheme to establish its safety and feasibility of rollout in local health contexts. About 450,000 doses have been administered so far in Homa Bay, Kisumu, Migori, Siaya, Busia, Bungoma, Vihiga, and Kakamega counties.
This phased introduction of the malaria vaccine in Kenya, as well as the 2 other countries in Africa, has reached a marked milestone, with children now getting their 4th dose of the vaccine.
According to WHO, a total of 650,000 children have received at least 1 jab in the pilot scheme in Kenya, Malawi, and Ghana, who are participating in the pilot. The malaria vaccine, RTS, is the first and to date the only vaccine that has been shown to reduce malaria in children.
Therefore, to succeed in our mission to end malaria, we must address financial and resource gaps that hamper the implementation of our malaria strategic plan. We have a financial resource gap of Kenya shillings 24 billion to fully implement the current malaria strategic plan from 2018 to 2023.
Malaria risk in the country is heterogeneous. Ending malaria depends on me and you by taking precautions like sleeping in mosquito nets and seeking medical help whenever you have signs and symptoms.
Thank you, Beldin, for that story. Now, Professor Ogutu, while we are talking about this as if it is a given that everyone knows about it, there's a portion of the population that perhaps has no idea that there is a vaccination going on. So could you talk to us about the state of vaccination in the country against malaria? Where are we as far as that rollout is concerned?
Thank you very much. And just to possibly put it in perspective, as stated, the development of the current malaria vaccine that has actually been registered and approved for public use has been going on since 1987, when it was first tested and shown to have effect, and initially was being developed for adults and was proven not to be effective in adults, and later on turned to be developed for children. And then in children, we found that it was much more effective in children between the age of 5 months to 17 months. It was not much efficacious in children that are basically less than 1 year old, and I think that's less than 6 months. And I think that's where the vaccination is from 5 months to 17 months. And this has been going on, and it was approved by around 4 years ago. And after that, the WHO came up with a recommendation that because of the way it is being given and some of the glitches that were seen in the last stage of development, there was need for a phased introduction of this vaccine, and that's why the vaccine is currently being deployed in 3 countries, that is Kenya, Malawi, and Ghana.
Right.
And this kicked off in 2019. There was a delay in getting this done because money had to be raised to support this whole phased deployment, which has been going on from 2019 when we started, the first children received this vaccine. And this has been going on in the counties with the highest burden of disease in Kenya.
And in Ghana, we are told we have 230 children vaccinated, Kenya 180,000, and in Malawi 220,000. Like we've heard in the story by Beldine, there is a financial problem. Rather, the country has other problems, and therefore, it's implementing that strategy is quite a challenge. So, when it comes to malaria, what do you foresee? When do you foresee this being a fully fledged operation? And even the buzz surrounding malaria vaccination cannot be compared to what we used to hear about polio, measles, and these other diseases. It's quite, for lack of a better word, low-key. Could you explain to us why we are not going all guns blazing about it? Is it the funding problem, or is it the phasing that you've talked about?
Okay, I think one of the drivers for the lack of much more pompous deployment is basically the phased-in stage that we are in. That we are doing the phased-in, and the first phase of this, which is going on in these 3 countries, is going to take us 4 years. So by 2022-23, we'll start looking at the data, and that will inform whether we need to roll this out broadly. And I think that time that will happen. But I think a lot had happened in the background earlier on, and I was able to participate in this because by the time the malaria vaccine was entering the last stage of development, there was quite a lobby within the international community to ring-fence money that should be made available immediately. This vaccine was going to be available to purchase it for the countries that need it.
Yes.
And this was done quite ahead of time, and the resources were basically ring-fenced. And I'm sure once we get the data after this the initial phased deployment that we are going through, there's going to be quite a big push if the data shows that we need to go on large scale, and this is possibly going to happen. And I think that's where we are. And I think we know that we'll never have enough resources for any of the public health interventions. And it is good that since the Kenyan president became the chair of the African Leaders Malaria Alliance, he's instituted the role of trying to get local domestic resources by creating the End Malaria Council that is going to galvanize and possibly generate resources locally so that we can own the problem and also own the way we are going to manage this malaria in country. And I think this is very important. And now that is leading the African leaders on this, I think these are a step in the right direction. And some of these interventions will be put in a much more better way than had been done before.
Right, and as the vaccine pilot program goes on, one would hope that it is safe, because a huge challenge when it comes to rolling out new vaccines is the concern that will this harm the people that it's meant to help. So when it comes to this malaria vaccine, what say you about the safety concerns and perhaps the things that have been done to ensure that it is safe for the children that are getting it?
I think if one talks about safety for this sort of vaccine, if the malaria vaccine, of all the other vaccines, one vaccine that has gone through a very rigorous trial.
Yes.
By the time the vaccine was getting to the level of approval by the European Medical Agency, there had been more than 65 studies done on this vaccine in different parts of the world. And this all hinged on safety, and even safety and interaction with other vaccines if it is given with other vaccines to children. And this all proved, by the time the approval was being granted, it was shown that the vaccine is safe and can be used in these areas. And one of the things that was done immediately after the approval was, if we are going to go for a large deployment of this vaccine, do we really know what are the background rates of some of the rare events that can be seen when children are given vaccine? And before the phased deployment, in Kenya, especially in Western Kenya, in Kisumu County, there was a background follow-up of children who had received other vaccines who are in the community to see what are the reports on some of the rare events that happen when children get vaccine, so that we can know when we introduce the malaria vaccine, are these events increasing or they have remained the same. This will help us understand and know that any effects that we see might be purely incidental and possibly are not related to the vaccine. And this is what we are going to use to compare the data that we generate from this current phase deployment. Safety is not a major concern when it comes to this vaccine. And I think this phase deployment also is that the way the vaccine is being introduced in the health system is different from the rest of the EPI vaccines. And we wanted to see how this affects the health system, so that when the large deployment comes, all these health system issues that would impede the effectiveness of the vaccine can be ironed out.
Right, but even with that, you have mentioned something about the data being collected. When it comes to COVID-19, what we have witnessed, even with contact tracing, at some point it became extremely difficult for government and concerned agencies to keep up with infections as far as tracing who was with who at what point. So when it comes to this vaccine and malaria, how are you ensuring that those that get it, the children, even as they face side effects, let's talk about those very rural areas. How are you ensuring that you keep up with those that got it, and ensure that you are following up and making sure that all the data that is gotten is accurate?
Thank you very much. And I think for the malaria vaccine, it might be easier because we are dealing with a fairly controlled areas that we know who is getting the vaccine, and there are already systems that we follow up these children in the community. And in some of the areas that we are doing an in-depth follow-up, we have control areas where the children have not been vaccinated. And we have mapped those areas, and we know which homestead each child is staying in. And all these children are seen periodically, and we pick all the events that happen. And for malaria, that is well captured, and I think we'll have all these details available. If they are admitted to hospital, somebody is there to follow up to make sure that we collect all the data, that what happened when he got admitted, what was the reason for the admission to hospital. And I think all this data is being collated, and once we get at the point where we need to start analyzing, this will be done and reported.
All right. Now, recently, Joe Biden, the President of the United States, made an announcement for those who have gotten the vaccine for COVID-19. They may be able to go out and even discard their masks when it is, because being outside poses a lesser risk for getting the coronavirus. So when it comes to the malaria vaccine, Dr. Masika, can you make some predictions on what we would have to do? Do you foresee a situation where the traditional nets and all the other things that have to be done to keep children safe from malaria shall be put aside?
The simple answer to you, Trix, is no.
Okay.
Vaccine is an additional, a very good addition, I have to say, in the effort of controlling malaria. But that does not mean we throw away things that we've seen work very well, like mosquito nets. So the short answer is no. We shall continue to do everything that we know that works until malaria has been eradicated.
Okay, but then even if as we look out for possibilities in the near future, what do you envision as far as the situation is concerned? Are we going to have children that cannot, when it comes to the efficacy of the vaccine, what kind of population shall we have when it comes to the risks posed by malaria?
I'm not sure I understand your question.
Shall they be? Shall they have a lifelong immunity? As in, when it comes to COVID-19, we know for a certain period of time these people shall be immune from the virus. What about malaria? What can we hope for from these children if it is successful?
I will let Prof. Omutu answer that, because I'm sure he's following up to see the duration of immunity they are seeing in these children. Yeah, although that is his area, I would rather let him comment on that.
Okay, Professor Guter?
Thank you very much, and I think this has been a very thorny issue, because one of the reasons why we follow up these children for long is actually determine the time period that possibly the vaccine effect starts waning, and that's why they are getting a booster dose at 2 years after the first dose to make sure that we sustain the level of immunity that they have acquired. We hope this will tidy them up till the age where they more or less cannot get severe disease and prevent them from possibly coming down with severe disease. And I think that's the main thing, that if they have any disease, it will not be that severe, that likely to cause mortality. And this is something that we are following up closely. And what we know is that the current vaccine was the first generation malaria vaccine, and there's a lot of work going on to make sure that we come up with a second generation that is slightly more better in terms of efficacy and also in terms of effectiveness within the health system.
Okay.
And that's why we have this new vaccine that is being reported that from the phase 2 proof of concept study in Burkina Faso has shown a better efficacy, which now has to be proved whether that can be sustained in a large population in different areas in phase 3.
Okay.
And I think the vaccine that is being reported from Burkina Faso is based on the same construct that the RTSS vaccine that we are deploying now is. And possibly the combination of the adjuvant that is added to it was what was tweaked around a bit also as well. So more or less it is based on the same stage of the parasite.
All right.
And I think that's what we hope will happen.
Okay. And perhaps when you look at countries such as China, we have them having rid themselves off of malaria, yet they were dealing with it on levels, perhaps on occasion, just like us, very high levels. So what is it about these countries that they have been able to rid themselves off of malaria that is not happening in African countries? And can't we just copy what they did? What is the difference between some of these countries that have managed to get themselves, rid themselves off of malaria?
Thank you very much for this question, and I think it's something that has been asked several times. And one of the things that the malaria transmission relies on a number of environmental dynamics and also population, and I think we have possibly some of the best, most efficient vectors in Africa that transmit the disease.
Okay.
And also the climatic parameters are possibly very well for it. If you look at the lake endemic area, is that basically we have transmission throughout the year because of the temperatures and the rainfall pattern. And this, if you go to places like DRC Congo, South Sudan, this is more or less what we see. And I think we have also not invested heavily in terms of what can be done and deploying all the tools that we need.
Okay.
And I think that realization has now come in Africa, and I think there's quite a big push. And we know that Kenya now has the End Malaria Council.
Yes.
Nigeria has put up an elimination agenda as well. And this is now putting in place where we want to start shrinking the map for malaria in country, where we go for the areas that have low transmission. Can we put intervention that we can possibly eliminate malaria in those parts of the country and start moving that closer towards where the disease is more with time. And so in the next coming years, we'll start seeing different ways that we'll start using some of the drugs and even deploying certain tools in the control of malaria to start creating this elimination agenda at country level, which was previously being looked at much more regional agenda. But this will be also linked to a regional agenda, but with a much more focus at country level. Can we start eliminating malaria in certain areas of each country that are more or less likely to possibly have seasonal?
Would I be playing to conspiracy theories if I stated that perhaps there's a hidden agenda when it comes to dealing with malaria in Africa? Perhaps there's something to be gained by it being dealt with this way through a vaccine that would, of course, as we talked about earlier on, have ROI for some of these pharmaceutical companies.
Thank you very much. I think this has been thought that there's a conspiracy theory. And facts be put on the table. The big pharma company don't make money out of malaria treatment regimens or malaria drugs. One of the big pharma companies that produced one of the drugs that has remained on the table for quite a while was subsidizing the manufacture and production of this product to be availed to the rest of the world. And most of them give these drugs at cost in terms of what they sell it. And this is why possibly it has also slowed down the development of new products, because some of the new products that are currently now being tested stayed in the shelf after they were shown to have effect for a couple of years, when the companies felt that until the government or philanthropic organizations come to share the cost of the burden of the early development so that the price can be maintained low. And I think those are some of the things that people need to know, that people would be happy with no malaria, because I think it is not a disease that you are going to make lots of money as a manufacturer of a new drug. And that's why currently we are pushing in for a different way of deploying the drug, so that the new drugs that come up can find their way into use, so that the companies can at least plow back their resources, just even if it is at cost, but those drugs don't sit on the shelf where they are not used, and possibly this will discourage any new innovations, because we know the parasite will be resistant to any drug that we come up with after some time. And we have to come with modalities of how we are going to deploy these drugs to ensure that resistance doesn't develop very fast. And that's why in the coming years, you will start hearing the jargon of multiple first-line treatments in malaria.
Okay. Now, Dr. Masike, so we don't leave you out of this conversation, I'd like your take on how the overweight, or rather the overburdening of the health systems right now by COVID-19 might be better if we are handling other diseases better, such as, you know, if we talk about malaria and other diseases, if we are handling them, or rather explain to us how COVID-19's weight on the health system is causing an impact on the treatment of other diseases such as malaria.
Thank you again, Trix. Initially, there was a big concern that people were afraid of going to hospitals, especially those that have been labeled as COVID treatment centers. And that was actually observed at some point last year when especially vaccine uptake and chronic care of chronic conditions like, say, diabetes or hypertension was reduced. But I think as we turned the year, people found a way to access these services, and the clinics or the hospitals were innovative enough to reach these people through different ways. So right now, our overburdening of the health system is more on the ability to care for the patients with COVID, because if you have exhausted all your beds, and it means you cannot take care of additional patients who may get COVID-19. And I think the prof observed that even with malaria, the impact on care was not as big as we had feared. So I think that's a good thing. We had that fear, and it was observed initially, but I think right now even people with other conditions are getting care. And once in a while, we see stoppages, especially of clinics or what we call elective theaters or planned surgeries.
Yes.
But I think it is not as bad as we had anticipated to be. Our biggest fear with the overwhelming the system is that people with COVID-19 would have received good services, say enough oxygen supply, an ICU bed, get to miss out because these beds are full or these resources are stretched. That is the biggest fear. And that's why you see us being in lockdowns once in a while, to make sure we don't get to that space.
Right. And let's talk about immunization risk now, and I'd like to get your expertise on this element or this angle of the vaccination situation in the country. Millions of children whose immunizations have been disrupted by the COVID-19 pandemic, especially in Africa, are now at risk of life-threatening diseases such as measles, polio, yellow fever, and diphtheria. UN health agencies warned on Monday gaps in vaccination coverage have already led to serious measles outbreaks in Pakistan and Yemen. The agencies said that and are likely to lead to more pandemics, and as more regular childhood vaccinations are missed. The strategy aims to reduce by half the number of the so-called zero-dose children receiving no inoculation from 20 million to 10 million, among other steps.
Even as COVID-19 vaccines give us hope of light at the end of the tunnel, the pandemic has caused several disruptions to immunization services around the world. New WHO data shows that as a result of COVID-19, 60 immunization campaigns are currently suspended in 50 countries. That means about 228 million children are vulnerable right now to deadly vaccine-preventable diseases such as measles, yellow fever, and polio.
While there has been progress from the peak of the global lockdowns, routine immunization services remained disruptive in 37% of responding countries in the first quarter of 2021. Disruptions as a result of COVID-19 have made this problem even worse.
So what we need to support the recovery from COVID-19 is, and to fight future pandemic, is to make sure that we prioritize routine immunization. We must specifically focus on improving the situation for children and their families who do not receive any routine vaccine.
Right. Professor Gutu, have the vaccinations against malaria been impacted by COVID-19, as it's being pointed out when it comes to other diseases?
Thank you very much. I think that happened, and I think for this time, I know we were doing it in a controlled setting, but this was disrupted a bit and delayed in the time we wanted to get the children vaccinated during this phase deployment. And now their modality is to basically catch up and possibly got the children vaccinated. And I think this is cutting across the other vaccines. And I think that this just explains what we should be doing, which sometimes people shout against, is the campaigns that will happen, because you don't want that critical number of children that miss a vaccine that can easily trigger the occurrence of possibly an outbreak of the diseases that we want to prevent. And we know with the time, and this is work that is happening within the KP framework, planning for certain campaigns and outreach programs to ensure that we mop out the children that miss their vaccination, so that we don't end up with this pocket that can lead to an outbreak of a disease. And this, what has been done previously with a number of vaccines, to make sure that we mop up this population of the children that miss their vaccines at the scheduled times.
Okay, Dr. Masike, it's a balancing act for agencies and hospitals to ensure that kids continue getting their vaccinations, but at the same time deal with the risks of COVID-19 and the overburdened system. So what would be the ideal situation to you as a virologist, so that one issue is handled, but at the same time others are not neglected?
It's all about our organization of the human resource and also other elements in our healthcare system, especially the resources and materials. We know the COVID pandemic interrupted supply chains across the globe, so we would need more logistical planning to make sure we don't run out of drugs or vaccines or even other materials, because a vaccine requires, say, materials for injection. And if these are not available, you have issues. So it will just take extra planning and extra effort by our government and our healthcare workers to make sure we have enough healthcare workers on the ground to take care of COVID, but also take care of other diseases. Because if you expect somebody who is running an isolation or wants to go, and a nurse who is running an isolation wants to go and administer vaccines, then you're probably stretching them too much. But if you allocate enough resources to that front, then you find the task easier to manage. But we need to move out of the comfort zone and deal with these issues head on. I know there are already efforts around that, and I think one of the things, as Prof has intimated, is that at some point we might need to do a mop-up vaccination exercise for those children who did not get immunized. And we need to keep reaching out to patients, especially those who are on chronic diseases that have not, either have missed their clinics for some reason. They can be reached by phone through what we call community health volunteers and what have you, to actively follow them up and make sure they are doing well, and make the follow-up easier, either by giving them longer follow-up visits, so that if you're supposed to come for after a month and you're doing well, you can be given 3 months. This is already happening in some instances. So there are many ways, if you focus on the logistics, you can deal with the issues. And this requires facilitation in terms of personnel and supplies, of course, as well as the will and the push to do it.
Yeah, but then it just boils down to funding, right?
Yes, of course.
Now we're not swimming in funding right now. So, I mean, what will happen to these children?
The cost of immunizing children is far less than the cost of treating them.
Yes.
So as a government, we have to find ways of reallocating our resources to the most impactful approaches. And vaccination is one of those approaches that we cannot afford to ignore.
Absolutely. Now, Professor Ogutu, I'd like your closing remarks on this discussion. Malaria vaccination, what can we hope for? And perhaps can we foresee a situation where the entire continent shall be immunized against malaria and have lifelong immunization, given the statistics and the data that you've collected so far?
Thank you very much. And I think the main thing that is going to drive to make sure that everybody gets vaccinated is when we have the vaccine that can be given across the various age groups. And I think this is something that there are few vaccines that would work across that. And malaria is fairly a fastidious parasite that you get a vaccine and you realize it can only work in a group of people. And I think this basically depends on the way the parasite behaves with the body at different age groups. And I think these are some of the obstacles that I think will have to be surmounted by technology. And I think as we refine the way the vaccines are developed and tweak them around, we might get a vaccine that might work across the different age bands. And currently, the drive is focusing on the groups that are more vulnerable, and that is the children under 5 years. If we can possibly get a vaccine that would work in that age group and possibly prevent the disease for long, so that these children move to teenage and possibly adulthood without having to succumb to the disease. I think that's the initial drive. But I think if a vaccine is going to, knowing about the current data, if a vaccine is going to be available that is effective, it will definitely be accessed by the population that need it. And I think this has been one thing that has been driven by the global initiatives.
Yes.
There's a group that meets every 2 years, and that is the Global Vaccine and Immunization Research Forum. And that body actually works with the WHO closely, and we review the landscape of the vaccines and the diseases to see which disease needs investment for our vaccine and which vaccine needs attention so that it can be progressed fast to make sure that we have the greatest impact. And even this year we had to meet last year. That was not possible because of COVID, but the meeting was held virtually this year in March. And there are very new innovations that are being brought up to tackle different diseases and the way to start packaging vaccines to ensure that we cover as much of the population as much as possible. One thing that came out of that group, actually, if there were no discussions early in the last 8 years in that Global Vaccine and Immunization Research Forum, we would not have had what we have had with COVID vaccine development. It is in that group that it was decided that there's need to start ring-fencing money for developing innovations for epidemics because of what has happened in the last 10 years.
Indeed.
And that led to the formation of Coalition for Epidemic Preparedness Innovations. And that is the platform that already had money and has been funding development of some of the vaccines and possibly platform for developing vaccines for even the coronaviruses. And that is what was latched on when COVID came in, and that's what actually catalyzed this first possibly development the vaccines for COVID. And I think this is now being seen as a driver for even other diseases, even the old diseases that have been existing. And some of these platforms, we'll start seeing them in use in some of these diseases that we have been working on to get vaccines.
And before I let you go, I would like you to comment as well on the thought that there are some people amongst us with a resistance, or rather a natural, immunity against malaria. Is it fact or fiction?
The issue of natural immunity to malaria is that there are things that has happened, and I think if you look at people who might have the abnormality in their red blood cells, especially those who have traits for what we call sickle cell, don't get severe disease, but they have other problems that if you have sickle cell disease, then you are more likely to die from the problem of destroying your red blood cells. And there are some genetic makeups that might make people less likely to have severe disease, but they might get infected, but they don't develop severe disease. And also, why the vaccine for malaria took too long to develop is that despite being infected by malaria, you never get complete immune to the parasite. That if you move out of the malaria endemic area and stay in a place with no malaria, when you come back, you more or less lose that immunity. So this is the nature of the parasite, that possibly it is somewhat able to evade the immune system. And these are some of the things that make it very difficult, possibly. And people might say, I'm immune, but possibly you realize that after a while, you go back and you realize you get infected even if you're older.
All. Yeah, thank you so much, Professor Ogutu. And Dr. Masika, your closing remarks, and I'd like you to touch on as well on the situation with vaccination. Some people might be having the risk of only having one dose of the current AstraZeneca vaccine. It's quite controversial right now, a hot topic, and at the same time, the country is toying with the idea of getting other vaccinations, or rather other vaccine types for the population. What say you about that and that challenge that we're currently facing?
I don't think the risk of getting one dose has been a big issue. The thing is about delaying the second dose from 8 weeks to 12 weeks. And this could actually be a blessing in disguise, because although it is coming because of a delay in the acquisition of new doses, the current research shows that if you give the vaccine at 12-week interval, you get a better immune response. So more people are actually protected as compared to giving it at 8 weeks, or some people give it at 6 weeks. And so that is a good thing. The other question as to whether we can mix vaccines has two angles to it. One is that scientifically, what we know about these vaccines, mixing them should not be an issue. It should work. But the evidence right now is not hard on that. So we still have ongoing clinical trials to confirm whether mixing or alternating and interchanging vaccines will work. And this will look at especially whether the vaccines, alternating vaccines, will give us the same level of immunity, what intervals to look at, and whether there are any unexpected side effects. The good thing is that we know that the technologies, mixing the vaccines could actually lead to a more robust immune response and will make logistics easier. That when you come to get a second dose and the vaccine you got originally is not there, you can get a second one, and that is okay. That would be a good thing, and it eases the process. But right now, there are some countries who are trying it, but we do not have a hard and fast evidence to show that it works. So that is still ongoing, and hopefully in the next few weeks we shall have some data to show us, at least for some combinations, not all of them, whether they work or not. But our expectation, the general consensus in the scientific committee, is that mixing or alternating or interchanging vaccines is probably okay and possibly better in terms of generating an immune response, but we cannot rule out any say harmful or should I say reduced efficacy until we have the hard data.
Okay. Thank you very much, Dr. Moses Masika, putting vaccination matters as far as COVID-19 into perspective. Thank you so much for joining us live via Zoom. And we also had here in studio Professor Bernard Ogutu, who's a Chief Research Officer at the Kenya Medical Research Institute, KEMRI, and of course he has a very long list of